taking us through the objectives of the CME and also sharing what is the integrated approach and what is the vision of WHO and how we are intending to take this forward. I would invite Dr. Shobha for giving the inaugural address for starting the CME. Dr. Shobha, please.
Actually, yeah, thank you very much, UNFPA. Thank you, Bimla. Thank you, PGI, MER, Dr. Neena, Dr. Bharti, for having collaborated with Foxy on this CME. I also thank my faculty who have joined with me, Dr. Valke and Dr. Kadappa. See, actually, it would have been preferable today also if Dr. Alpesh Gandhi had been with us. I did send him the message. He has conveyed his best regards to UNFPA. He is delighted that Foxy is able to collaborate with your organization and with the Postgraduate Institute of Medical Research, Chandigarh. He is very happy that Medical College of this stature has also come into our fold today, and we are conducting this jointly. Well, a very, very strong message needs to go today to the audience that pandemic or no pandemic, the quality of our services should be unstinted, cannot be compromised. And as far as reproductive health is concerned, the nuances of COVID-19 infection impact, what are the changes in our services, how teleconsultation has come to play a vital role in our service delivery in the past 10 months will be deliberated today, and what exactly was the impact of the pandemic on the contraception and family planning services also will be spoken of. And I think there is an entire panel discussion to discuss about the impact on youth friendly services as well as FP services. So wishing everyone all the best, and looking forward to a very interactive session. I'm really keen that the audience should come forward and put their questions. That will make it very rewarding rather than only didactic lectures. Thank you so much. Thank you.
Thank you, Dr. Shobha. And as Dr. Shobha said, that this is really an opportunity for us to pose our questions. And I would request all the participants to type in their questions in the Q&A section, so that at the end of the presentation, we are able to address maximum number of queries the participants have. Now we start with the presentations, and the presentations will be followed by a panel discussion. So the first session is on COVID-19 and its effect on maternal health through conception up to the delivery. And that includes discussion on the vertical transmission as well. For this session, I will invite Dr. Bharti Joshi, who is Assistant Professor at Department of OBGYN at PGI Chandigarh. She will be discussing important issues. She is also the nodal person for COVID-19 and maternal health at PGI. And she will take us through all the important issues of COVID-19 and what the women have faced and what is the way forward on managing pregnant women with COVID and discussions around the vertical transmission. So over to Dr. Bharti.
Okay. First of all, my heartfelt thanks to all the organizers, to esteemed faculty for giving me this opportunity. Now I begin with my presentation. Is it visible to everyone? Should I start?
Yes, ma'am.
Okay. So as my first slide is saying that COVID-19 and pregnancy issues, confusion to conclusion. Definitely when a global pandemic was declared in March 2020, So we obstetricians start thinking differently. Why we need to think different? Because it was a unique challenge, because this pregnancy has some immunomodulation in the body. So definitely this is a vulnerable group. So how the pregnancy is going to behave, how this disease is going to be transmitted to the fetus, is it a long-term effect or it is going to be a transient effect? All these questions came to us as an obstetricians. So we need to think something different. And somehow it was not that this was a new pandemic. We had a very bad experience in past, that was with H1N1 and similarly with MERS and SARS-CoV-1 virus, which was in 2004 and 2009. So really at that time, there was a very high maternal mortality and morbidity up to the tune of 35%. So we were very scared. Is it going to behave like that MERS and SARS-CoV-1? Oh my God, if it is like that, we have to do something very aggressive. But now see what has happened over a past 8 months and how we have come with so many evidences, so many literature that how it is going to affect the pregnancy. It was not only that challenge that how it is going to affect maternal health, it was other aspects also, other major concerns regarding diagnosis, testing, because in the beginning it was being told that COVID-19 will have a mild symptoms like cough, rhinitis, congestion. And we see in pregnancy also, the most of the pregnant females, 15 to 20% of females, they come with the symptoms like rhinitis, congestions, and sometimes they can have a dyspnea related to pregnancy. So how these confusing symptoms are going to overlap with the COVID-19 and how we are going to make sure that this woman is probably have COVID-19 symptoms and this is related to pregnancy. Other thing was therapeutic controversies, whether we need, what diagnostic modalities we can use in pregnancy, because most of the time CT scan and chest X-ray was widely done in all patients in order to know whether the patient has a COVID pneumonia, what is the scoring, what type of treatment is to be given. But we have little dilemma of using CT scan as well as X-ray in pregnancy, and even giving remdesivir, antiviral drugs, safety concerns, giving corticosteroids and everything. So all these concerns were there in the mind in the very beginning. Maternal-fetal complications, is it going to cause more stillbirths? Is it going to cause more IUGR, placenta previas, preterm labors, or missed abortions, or something like a vertical transmission to the fetus? And definitely a psychological issue was also important, because these women, we all were there in the house in the lockdown measures, and we were giving consultation through telecommunication. So most of the women, they were sitting at home and they were not sure whether they were being taken care properly. So we have already talked about that therapeutic controversies were in the form of chest imaging. It was in the form of CT scan chest and options for antiviral and corticosteroid use. And psychological issues like postpartum care and depression issues, they are going to be precipitated in such a still scenario. So do we have evidence-based recommendations now? Because these were the questions who came to us in March. And for the past 8 months, all of us got opportunity to manage so many pregnant ladies with us. And now we are very clear that most of the time, if a pregnant lady who has a COVID-19, how we are going to manage that patient. So we have huge number of studies. Previously, it was a small case reports. There were only small case series or cohort studies. But now we have enough data. We have a comparative data also to say that how these COVID-19 pregnant females should be managed. So if the most important, and from where we can conclude and where we can have few recommendations or few policies, is the largest data that has been published in BMJ in October 2020, and it comprises the data of around 11,500 women. So what they have said, that overall rate of COVID-19 diagnosis in recently pregnant women, the prevalence is only around 10%. So this prevalence is not more than that of non-pregnant female in that reproductive age group. If we see a non-pregnant female in the reproductive group, she is going to have the same chance of acquiring COVID-19 as a pregnant female. So the one worry is gone, that whether these pregnancy females are more likely to have infection, less likely now. It is similar as compared to non-productive state. We had that fear in mind because we know in a pregnancy, there are two types of helper cells. One is type 1 helper cells and one is type 2 helper cells. Now type 1 helper cells, they are basically antiviral. So they basically protect us from any viral infection. In pregnancy, what happens? There is a dominance of type 2 helper cells, and that is because this this they help for the fetal rejection. Otherwise, there can be a fetal is a allograft that can be rejected by the female. So this is a T2 natural dominance. So we were scared whether the T1 cells are low. Definitely pregnancy should have a more predisposition to the COVID-19. But somehow, luckily, it didn't happen because there were other biology of COVID-19 infection in pregnancy that has come up with new strategy, new theories. So whatever they have said, that prevalence is 10%. And this prevalence has varied from 7 to 18%. 18% in those states, in those countries where people have tested on basis of symptoms. Like any pregnant female who is approaching to the hospital, they are not testing all. They are testing only those pregnant females whoever have the symptoms like fever, cough. Definitely, if you are testing a female based on symptoms, the prevalence is going to be high. We people in PGI, we are testing every female after the ICMR guidelines. They came up in June that every female who needs intervention within 5 days should be tested. So nearly we also have a prevalence of 6.8% in PGI, which I'm going to tell you later on. So this prevalence is not different from the general population. And the second thing they come out with, the important conclusion was that majority of the women were asymptomatic for COVID-19 infection. Almost 95% of the females, the pregnant females, they were diagnosed because of COVID-19 infection, that they went for the universal screening as they approached the hospital for their intervention, and they were found to be COVID-19 infection. So it means it was not a serious COVID-19 infection or SARS-CoV-2 virus in pregnant females as compared to MERS or SARS-CoV-1 virus. Another thing, this data or this meta-analysis and other systematic analysis, they also shown that most of the females who present with mild symptoms mean only 5% of the females who will have a symptoms. Out of these 5% also, 2-3% will have a mild symptoms. These mild symptoms will be fever and cough. Like 40% of the females, if they come to us, you will find they will have a mild fever and cough. You get them tested and it is found to be positive. Lymphopenia mostly has been seen only in symptomatic patients, and other C-reactive protein levels, altered ferritin levels, and D-dimers levels, they are also being seen to be altered only in a patient who are mostly symptomatic. So compared with non-pregnant women of reproductive age with COVID-19, pregnant women recently with the disease were less likely to manifest symptoms of fever and myalgia. This has also been seen with the COVID-19 systematic analysis. Now they have seen who are the females, who are the pregnant females who are going to have a severe COVID-19 infections. So what they found for underlying comorbidities, like the female who is pre-existing diabetes or who has pre-existing hypertension, and the females who were obese, they were found to be infected with the COVID-19 disease with severity, more severity. They have a score of more than 13 or more than 14 even on CT scan. And these were the females who needs intensive care or ICU care during pregnancy. So these were the 2 or 3 risk factors like hypertension, pre-existing COVID, pre-existing diabetes, and high BMI. So these were the females who needed ICU care during COVID-19 infection in pregnancy. So here another theory has also come up. What they have said that COVID-19, somehow we know it is a thrombogenic, but it also causes endothelial vascular dysfunction. So like in preeclampsia, what is happening in placenta, some changes are being there. They say this type of changes are also being done by this COVID-19 in these females. So they have an aggravation of everything. They have an aggravation of preeclampsia, they have an aggravation of hypertension, and they also causes the release of pro-inflammatory markers, and sometimes which we can cite, which we say is a cytokine storm in COVID-19. So this kind of behavior was, more aggressive behavior was seen more in pregnant females who had a diabetes and hypertension. Another thing which we had compared in COVID-19 with the pregnancy, now this is another literature which has come up, that it was an effect on mother, that now we are very clear from the literature so far, 11,500, more than this data is definitely significant and saying that you need not to worry so much because it is in most of the infection, it is a mild or asymptomatic. Another concern was whether it is, although it is less dangerous for mother, but whether it is more dangerous for fetus, probably no. early pregnancy loss, teratogenicity, second trimester loss, fetal growth restrictions. These kind of complication was seen in previous viral infections with the pregnancy, even with torch infections, even with the H1N1 infections, MERS and SARS-CoV-1 infections. However, we are lucky enough to say that till date, whatever evidence has been there, that only studies have shown that it causes increased preterm labor. But that is also, we have to very intelligently, we have to interpret that data, because in beginning, what people have done, they have induced the patient in premature gestation because of fear of COVID-19 behavior in pregnancy. So most of the time, this preterm labor was iatrogenic, like a patient who comes to me at 33 weeks with the preeclampsia or 33 weeks with placenta previa, and I'm scared how this female, she is COVID-19 positive, although she doesn't have symptoms, but I'm scared how I'm going to keep this placenta previa for a long time, how if she bleeds in emergency, how our team is going to handle. So most of the time, what people have done, iatrogenic preterm deliveries have happened more as compared to spontaneous preterm labor. The incidence of spontaneous preterm labor was just around 6 to 7%. It was overall, it was seen to be up to the tune of 17%. So it has also not varied much as compared to the pre-existing background data. So probably now we are sure enough to say at least that pregnancy doesn't have many morbidities to the COVID-19 infection, does not have many morbidities to the fetus in terms of fetal growth restrictions, in terms of stillborns, in terms of neonatal deaths, in terms of missed abortions and other things. However, somehow there has been found to be a slight increased risk of preterm labor. Another concern was vertical transmission. Definitely, whenever a female acquired infection during pregnancy, we all know that it can go to the fetus through amniotic fluid, through cord blood, vaginal secretions. Even there can be postpartum transmission through breast milk. However, whatever data we have about vertical transmission is that it can happen to some extent, but that data is not much. It is around to be seen in most of the meta-analyses and systematic reviews that it is up to the tune of 3.2%. So why we were scared in the beginning that there can happen a vertical transmission? Because previously the theory has come that the COVID-19 virus have ACE2 type receptors through which it acts and can influence any target organs. Like we have a respiratory epithelium, we have ACE2 type of receptors. In placenta, trophoblast, syncytial trophoblast, endothelium, ovary cells, sperms, everywhere there are ACE2 type receptors. If they are so widely expressed, why not COVID-19 is infecting so much? Because later on it was realized that it is not only ACE2 type receptors, there has to be interaction of ACE2 type receptors with the transmembrane serine protein expressions also. So these two have to act in concordance with each other in order to have serious COVID-19 infection in pregnancy. That's why even placenta can have a ACE2 type of receptors, even endothelium can have a ACE2 type of receptors, ovaries can have, tubes can have, but the morbidity and transmission is not so severe as it was previously thought of. So now we are very clear from various systematic meta-analyses, whether they have done in 1,000 pregnant females or whether they have done in 11,000 females, and even the renowned bodies like WHO, CDC, ICMR, FOXY, and everyone is saying now that we need not to be scared of so much about COVID-19 in pregnancy, and every female has a right before, during, and after childbirth, or they have the right to have a high quality care. This means we need to give them a good antenatal and intrapartum care. We need to give them a healthy newborn with all the postpartum care, postnatal care, and even the contraception. So what exactly what kind of advice now we need to give these pregnant females? Now we know that we are very sure of many things of COVID-19 in pregnancy. So first of all, any female, you come to know that she's found to be COVID positive by routine screening or somehow from symptom-based wise, what exactly we need to know that how we can provide a optimal care is, First is we should know about the tele-consultation, how we can provide a tele-consultation to any pregnant female who has come positive. For that, we need to know what are the various warning signs of COVID-19 in pregnancy, and what exactly we need to look extra apart from her routine antenatal care. So this type of knowledge we need to have before we provide any kind of consultation for a COVID-19 in pregnancy. So any female, if she consults, she says, I'm 18 or 20 weeks pregnant, doctor, and I'm diagnosed to have COVID-19 positive because my father-in-law or my husband is found to be COVID-19 positive. So should I provide her teleconsultation, or should I call her? Should I admit her? The very simple things which we need to know is, first of all, we need to reassure her. We need to tell her few facts that probably as you are asymptomatic, you are a high risk contact, that's why you have turned to be positive. Few things you need to be vigilant is, remain ambulatory. Tell her to remain ambulatory. Tell her to take plenty of fluids. Tell her to record her saturation at least 4 to 5 times a day, and look for her vitals, and explain her warning signs whenever she has a disproportionate dyspnea or her saturation goes below 95%. If all these things are there and she is comfortable, she doesn't have any kind of symptoms, you have explained her all warning signs, she can be taken and she can be given a home care for this asymptomatic COVID-19 infections. But if she says, doctor, previously I was fine, but now I have a fever which is more than 38 degrees centigrade, it is not coming down. I have seen my saturation, previously it was okay, but now it is 93, 94%. And I am feeling that I have a tachypnea or respiratory discomfort, and blood pressure is also going down. In those cases, and other thing which we need to know is, she should not have coexisting comorbidities, because whenever a pregnant female have coexisting comorbidities in form of high BMI, in form of diabetes, in form of hypertension, she automatically goes to category B. And category B is a type of category of COVID-19 illness where we need a kind of evaluation by admitting the patient, and sometimes we need to give a heparin prophylaxis to these females. In all these cases, any patient who has a coexisting comorbidity or has a warning sign which I have already explained, you need to ask the patient to come to your COVID wing or to come to your suspect area, where you can evaluate the patient by making her indoor. Another thing which is required to do specific for this COVID-19 is, we need to look for other laboratory parameters, like leukocytopenia is severely seen, lymphocytopenia, they say count less than 1100, and similarly leukocyte and lymphocytic count markedly raised. So they are the poor prognostic factors. Increase in C-reactive protein definitely can be seen in non-pregnant females who have a COVID-19, but in pregnancy this interpretation is going to be little dicey. Then raised D-dimers, we need to understand that in non-pregnant, the D-dimer levels are only up to 500, but in pregnancy up to third trimester, it can go up to 1700. So
2 minutes, Dr. Bharti, you have 2 minutes now.
Okay. But in pregnancy, you have to be little vigilant that it can go 2 to 3 times higher. So all these interpretations has to be there. And if indicated, please go for chest X-ray or CT chest if it is indicated from Mother Health, because even in CT chest with the shield, the exposure is very, very less. So we need to know. Then intrapartum care, definitely delivery, it has to be same as for the other females who doesn't have COVID-19. You need to monitor fetal heart very strictly. Better to give her a epidural or regional anesthesia so that aerosol generator procedure is avoided. And in vaginal delivery has to be an option for all females, like in other without COVID-19. We don't have a direct indication for doing the cesarean in COVID-19 until that patient is critically sick and you want to improve her mechanical ventilation and you feel that she cannot deliver vaginally. That is the only indication where the cesarean is indicated in COVID-19. Otherwise, all indications as per obstetrical conditions. Now coming to the maternal stabilization before intervention, that definitely if patient is sick, so you have to think of mother before baby. Then coming to the whether we have to advise for the breastfeeding or whether we have to make a temporary separation, that has to be discussed with patient, because the vertical transmission incidence is found to be very low and that reports are very discreet and they are also not very conclusive. You just have to tell the mother that you breastfeed your baby because this is the ideal food for the baby, but you have to maintain a respiratory hygiene, and that that can be done. Even WHO, CDC has promoted that we need to give the respiratory hygiene and we need to promote the breast milk. Another important thing, role of thromboprophylaxis. Please make a chart. Give almost every female who has a cesarean, who has at least one morbid factor, she has a transient COVID-19 infection, please give her low molecular weight heparin. Whoever has been admitted in the hospital, the patient who has self-isolation at home, you can ask her to have hydration and encourage anticoagulation. Role of HCQ is not there. Previously we were giving, but now we have enough literature saying that there is no role of HCQ. Other things which we are giving in pregnancy usually is this adequate hydration. If she has a pneumonia, then we can give the cephalosporins. Steroids, yes, we have given in 2 patients dexamethasone, because she has the GGOs with ground glass opacities in the chest, and we have a certain protocols in the PGI Chandigarh. Until now we have tested 2400 pregnancies for past 8 months. 165 positive patients we have treated so far. Out of these, 15 had vaginal delivery, 74 has cesarean delivery, few came postpartum, few were post-abortal, and all the patients, they went fine. So we didn't have a serious kind of morbidity with this. So in a summary, I have already said that we nothing have to fear regarding COVID-19. Treatments guidelines are very safe and policies are there. So we need not to worry much about, and we have to give optimal care to the pregnant females as were giving previously also, and rooming and breastfeeding acceptable under appropriate preventive measures. Thank you.
Thank you, Dr. Bharti, and I'm sorry I had to interrupt you, but you very crisply, it was a very crisp presentation, and you really dealt with all the practical aspects of managing a COVID-19 woman, pregnant woman. Thank you so much, and I'm sorry for because
My pleasure.
is also important. Thank you so much, Dr. Bharti. Now I invite Dr. Dilip Walke for discussing the next session, which is on the role of tele-consultation in antenatal and postnatal care. And as you all know, Dr. Dilip Walke is head of department of OBGYN department, Medipoint Hospital, Pune, and he has a vast experience of like he has designed an app also for teleconsultation. He will take us through this important aspect, because COVID has brought in digitalization in medical field to a very, very big way, and it is a boon for continuity of antenatal and postnatal care services. So over to you, Dr. Dilip, for the next session.
Yeah, thank you so much. I'll just put off my phone so that we will not disturb. Okay, thank you so much for the kind introduction. I bring you greetings from Pune. And I say thanks to UNFPA, PGI, and Foxy, especially Dr. Shobha and Alpesh, because every time there is something to do with teleconsultation, they call me for giving the talk. So thanks for that. But before that, a disclaimer: at this moment of time, even if I'm staying in my house, I'm speaking from there, I'm getting butterflies in my tummy. The reason is I'm the only non-academician among the all elite faculty of professors and associate professors, and even Shobha, for that matter, is almost a professor, because I know her, she is a thorough academician. So I'm feeling like an odd man out here when I'm talking about any topic. However, I'm going to speak very confidently today, because I know I've seen this slide which says the problem with the world is that intelligent people are full of doubts, while the stupid ones are full of confidence. So I am going to talk with lots of confidence today, and my stupidity for the next 15 minutes will be on role of telemedicine in ANC and PNC. And Dr. Bimla, you can stop me anytime my time is getting over, because I don't want to step into the other faculty members, because I'm more interested in listening to them rather than speaking myself. My approach to this talk would be with special reference to ANC and PNC. What we'll do is we'll look at the legalities of telemedicine in our country, and we'll try to find out some practical tips and tricks for its use legally. And then we'll go on maybe 1 or 2 slides on smart use of all the platforms that are available, the Government of India platforms and the private platforms which are available for teleconsultation. The legalities we'll try and finish off in a rapid fire kind of a way, because almost everything is now known to us. So the point number 1 is, telemedicine going to be allowed only during this pandemic? Because we are talking only about COVID today. So it is going to be allowed only for pandemic or even beyond? The answer is yes, it is going to be allowed even beyond, even after the pandemic is over. Are we expected to clear some certificate course before we start this teleconsultation? The answer is yes. An online course is going to be there, but it will come up only after a couple of years. At this moment of time, everybody in the audience is allowed to do teleconsultation. Are we allowed to charge for our consultation? The answer is yes, we can charge for our consultation. Are we allowed to tie up with some private platform provider for this consultation? The answer is yes. But are we allowed to solicit patients, especially for the private practitioner? Are we allowed to solicit patients by using patient acquisition models of these private platform providers? You have to be very careful here, because now it is NMC, not our NCI. The NMC is one which is almost controlled by the government, and we are not allowed to solicit patients. And so you have to be very careful about these private platform providers who come to you and say that we will solicit patients for you. Now, is it legally safe to give antenatal and postnatal care on telemedicine? That's what we want to know today. Our professors always taught us that doctor-patient interaction, especially in ANC and PNC, involves history taking, physical examination, investigation, and then treatment. And please don't kill me, all this professor, because there was a time when I used to talk about teleconsultation before the COVID and before it was allowed. Every professor, and I'm sure everybody who's sitting here, all the associate professors and the professors who are here as a faculty, would have killed me if I had told them that 60% of the time in my ANC and PNC, I do not examine the patient, because I am doing consultation only for minor complaints needing simple and safe drug. I do only adjustments of drug dosages of the antihypertensive or the anti-diabetic that I may have given, or I consult them for appointments or procedures or surgery, or I give them reports on investigation reports. And 10 to 15% time, I can manage these issues on the phone or a WhatsApp. And I did use telephone and WhatsApp consultation at that time, even before the COVID, with a constant fear of litigation, because you knew that there were a Supreme Court judgment, there were some High Court judgments to say that teleconsultation is illegal and you cannot give advice on telephone or a WhatsApp. But after 25th March, everything changed. We became very fearless because the MCI came out with telemedicine practice guidelines, which now allow us teleconsultation. So now we are fearless about teleconsultation. In fact, everybody now started talking about teleconsultation. I'm very happy to see that many of the professors and associate professors are now talking in favor of teleconsultation. So now let's try to find out what is the scope of telemedicine in ANC and PNC. The TMP guidelines tell us that the teleconsultation can be used for three things: either health education, and here when it comes to ANC and PNC, we are talking about diet, we are talking about exercise, we are talking about healthy lifestyle, vaccination, contraception. So all can be done in under the telemedicine. You can do counseling about specific health related issue in ANC, PNC also, and also you can prescribe medicine. But when it comes to prescribing medicine, there are some categories of drugs that we can prescribe during ANC and PNC, and these categories are there in the guideline. They say there is a list O, which are all the safe drugs, like the OTC drug or the public health drug. Like in malaria, you give chloroquine. So these are public health drugs. These can be given on telemedicine. And when it comes to ANC and PNC, then hematinics, supplements, vaccines, all these can be prescribed on telemedicine, teleconsultation. Then the list A is relatively safe drug, which can be used as a first video consultation, and these are for eye, ear, or skin. We're not concerned with ANC or PNC as much. But our refill drugs, when the patient is following up with you with hypertension, she tells you about her BP on the telemedicine practice platform, and you give medicines for her, or the diabetics or the asthmatics. All these refill drugs again and again after 15 days can be done on telemedicine. And these relatively safe add-on drugs can also be added, say adding a new drug to the like supposing you have given some antibiotic and then you want to add on something else to the antibiotic, some painkiller. All this can be done, but you have to be careful that narcotics and psychotropic and anti-cancer drugs are not allowed. And I feel that this is not the forum to talk about that, but I feel that a lot of advocacy is needed for us from our side to see to it that the board of governors even allow narcotics and psychotropic and anti-cancer drug, because these are also needed to be given on teleconsultation. The list is not exhaustive. It is going to be updated from time to time. So ultimately, it will boil down to only remembering those drugs which are prohibited. Eventually, everything is going to be allowed as we become more and more mature on teleconsultation. Everything will be allowed. Only we'll have to remember which drug is not to be given, and we have to use our own judgment to decide whether this drug can be prescribed on a telemedicine platform, or we need to call this patient for an in-person consultation. Is there a specific format prescribed for prescription? The answer is yes, there is a specific format. And even whether you're using an WhatsApp or an email, you're supposed to give this prescription in a specific format, which is including the patient's age, other details, the RMP details, including the registration number and things like that. So it is all available on the practice guideline. Another question is, can we use artificial intelligence for giving health education? At this moment of time, artificial intelligence is excluded from the guideline, but just because they are excluded doesn't mean this is a permanent exclusion. Eventually, the board of governors are going to realize that it will be better that certain things when it comes to ANC and PNC can be handled by an artificial intelligence also, so that things like diet, things like exercise, and advice regarding vaccinations and things like that can be taken over by an artificial intelligence also. Which mode and which digital platform can be used? Actually, any mode: audio, video, text, and digital data exchange. And any platform like a telephone, WhatsApp, mobile, Facebook messengers, video devices, all connected by LAN or WAN, any internet related thing like a Skype or an email or a fax, everything that you know can in a digital platform is allowed, and in any way like an audio, video, text, or digital data exchange. Now, is an explicit consent required before we give an advice on the telemedicine platform? If the patient is initiated the telemedicine consultation, the consent is implied. But if we have initiated the teleconsultation, then we need to take a consent, but that is going to be an explicit consent. I mean, you don't have to get or sign a consent form the way we do it before a surgery. Even an explicit consent, which can be recorded in form of an email or a text or an audio video message, that is good enough. So that is about the patient consent. Next thing is teleconsultation allowed for emergency? Now, 0-hour life-saving advice can be logically given. Just because somebody called you and she's having a lot of bleeding and antepartum hemorrhage, you cannot just cut the phone and say that you don't talk to me, just go to a hospital and get yourself examined. If she's got severe blood pressure, if she's got eclampsia, if she has got bleeding, if she's got a loss of fetal movement, the initial advice can be given for something. If you feel that she's going to need a surgery as soon as she comes to the hospital, minimum things like don't eat anything and things like that can be given. So a 0-hour life-saving advice can be given, like somebody is having a myocardial infarction, some symptoms suggestive of that, then you can also tell them about taking an aspirin, taking a clopidogrel and things like that before reaching the hospital. And then you have to guide the patient for proper referral to a tertiary care center. This is what is expected from you in an emergency. So is telemedicine consultation allowed in emergency? Allowed to that much extent. Can you give ANC, PNC advice on your first consultation? Now, here there is a little catch, because the first consultation, as per the guidelines, say that it is allowed, but it has to be a video consultation, number one, and it is allowed only for eye, skin, or ear condition, which means, is it not allowed for our ANC or PNC consultation? Now, this is where we need a lot of advocacy with the board of governors to say that it should be allowed for first consultation also, which could be a video consultation where the patient contacts you and the patient is given all the advice. A gap between the two consultations to be called as a follow-up consultation is 6 months, which is a very big gap. So if the patient is seeing you today, and then the patient within the next 6 months can do a teleconsultation, and that is considered as a follow-up consultation. 6 months is good enough time for us for ANC. For in ANC or a PNC care, you can always manage with teleconsultation. Some legal queries about telemedicine consultation is, what is the standard of care that is expected of you when you're doing a teleconsultation? The standard of care is same as if you're examining and giving the consultation to the patient. However, even the practice guidelines mention that the courts are supposed to give consideration of the fact that certain things cannot be absolutely known to the doctor because the doctor has not examined the patient. So even that has been mentioned in the practice guideline, which we can make use of whenever there is a case against you when it comes to a teleconsultation. Now, is confidentiality and privacy our responsibility? Yes, it is our responsibility, and that's the reason why we should use a telemedicine platform which is taking care of the patient privacy and confidentiality. However, whenever we are using a platform, we are not responsible for any breach of the patient's privacy and confidentiality if there was a technical snag. So a doctor is not made responsible of the technical snag. The private platform provider is made responsible for the technical snag. So this is a wonderful statement that has been actually captured in the telemedicine practice guideline, which we can make use of if there is a breach of privacy. Which are the mandatory documents to be maintained by us? And these are the documents. Log of the telemedicine interaction, whenever, whichever number of times we actually interacted, that log has to be mentioned. The patient's documents, if the patient has given you the document, shared the document with you on the WhatsApp or on the platform, that has to be maintained. And the prescription record has to be maintained. So this is our responsibility, and the telemedicine practice guideline has just left us having mentioned that these mandatory records we have to maintain. Now, what are the points that are excluded from the telemedicine practice guidelines? These are the point exclusions at the moment. Just because they are excluded today does not mean that later on they are not going to be touched upon. And these are the specification of hardware, software, data management system, and infrastructure. Fortunately, they have not told you about this. So at this moment of time, you can use any kind of a platform. Use for research activity they have not touched upon yet, but later on they will have to do it, because research activity on a telemedicine practice platform is going to make them, it is going to help the government to make a lot of policies. Use for consultations out of India, at the moment they have not touched upon, but then we should be able to connect with our patients outside India also, so that we can give them advice. Use of digital technology to conduct surgical or invasive procedure, like a robotic surgery, where somebody is doing the surgery here and the patient is somewhere else in the other part of the world, and the use of artificial intelligence, as I just told you. And what is considered as a misconduct by the doctor is this, that if the RMP is insisting on telemedicine while the patient is not, the patient is willing to come there and get herself examined before any advice, and the RMP says, no, I am not available for in-person consultation, you have to take advice on telemedicine. That is considered to be a misconduct. Or RMP misusing the patient's image and data on social media. The patient sends you something on WhatsApp and you are then forwarding it to your friends. That is not allowed. Prescribing medicines from specific restricted drugs. So at this moment, narcotics not allowed, anti-cancer drugs not allowed, psychotropic drugs not allowed, and soliciting telemedicine through advertisements and inducements. You cannot put an advertisement in the paper or even on or YouTube or any other platform to say that you are available for telemedicine practice. So this is not allowed. I always say that, many people ask me कि हमें private platform provider की जरूरत क्या है? I can always do consultation on telephone, WhatsApp, email. I have that with me. Why do I have to spend on a private platform provider? The reason is, on a telephone or a WhatsApp, it is difficult, number one, to maintain the privacy and confidentiality, because your WhatsApp is not leak proof. Your telephone can be tapped and your email can be hacked. So all these things are not leak proof. So that is difficult to maintain. To maintain all the mandatory records, you talk to someone on the telephone, you'll have to go back and write down, I had spoken to this patient at this moment of time, and this was the interaction done between me and her. Difficult to maintain. Number one, to prescribe drug in a prescribed format, it is very difficult to send a WhatsApp message to the patient in a prescribed format. This prescription cannot be in the format that is expected by the telemedicine practice guideline. That becomes difficult. And lastly, the most important thing in private practice is difficult to ask for payment on telephone or WhatsApp. You have done your consultation, you have given your advice. How can you tell the patient कि मेरे 500 रुपए भेज दे और कहाँ भेज दे? So that also becomes difficult. So that's the reason why there are several private platform providers. There are several government of India platform providers. You can choose from them and see to it that you can do or maintain all these records properly, and you can charge for your consultation also. So last slide, how to choose a good platform provider. Number one, it should be a mobile app with website support also. so that you can avoid social media platforms. Number two, it should support everything: audio, video, chat, and document exchange. So that also should be considered. Your data should be in an encrypted form. It should be a platform between you and your patient alone, and no third person should be able to access the record, because to third person, it should be seen only in an encrypted form. Even to the platform provider, only one or two people at the back end should be able to de-encrypt the data and should be able to decode the data. And that too, they should be, we should have a non-disclosure agreement with them so that they will not misuse that data also. There should be an easy identification for the doctor and the patient with all details. The patient can name, age, Aadhaar number or telephone number, address, and things like that. And doctors, same detail along with the registration number. Medical legal safety for doctors with clear disclaimers and consent. There should be proper disclaimers between the doctor and the patient so that medical legal safety is maintained. There should be a secure payment gateway to monetize the doctor. The prescription should be in a simple medication should be drafted as a ready-made template with provision for doctor's signature also. Now we are using mobile apps which are Androids, and there you can sign also with a provision for signature and stamp with a single port print option. Because if the patient can take 3 or 4 printouts of that, then if you give them some prescription, they can take, instead of 10 tablets, they can buy even 100 tablets of that prescription. So you need to see in some way should see to it that the prescription can be honored only once. So can we think of something like a barcode and things like that? This is the thing that I have been fortunate to interact with some of the board of governors, and we are trying to find out how it is really possible that these prescriptions are going to be honored only once and not 2 or 3 times. So we can use it fearlessly, using our judgment, and make a decision that this particular consultation that I'm doing with you can be done on a telephone or a WhatsApp, or an in-person consultation is required, so that you can call the patient for an in-person consultation and do it. So at the end, I think the punchline for everybody to our patients is, you should tell the patients that do not commute to communicate. You can always communicate with us on a telephone or a WhatsApp. Especially for an ANC or PNC advice, because you're pregnant and because the corona is so rampant now, you should not be traveling as much as possible. Just communicate with us on a platform. Thank you very much for a patient listening, and I'll be there for the question answer session later.
Thank you, Dr. Dilip. And it was very interesting and an enlightening presentation. And I couldn't stop you, although time was up, but I thought let us continue, because there are very few speakers who would be speaking. Who are giving speeches such as this. And you discussed the nuances of day-to-day nuances of telemedicine and teleconsultation, do's and don'ts, and it was very helpful. Thank you so much for this.
I'm sorry if my time was up, and I spoke for how many minutes more?
I think 2-3 minutes, not very much, but
Shobha, I'll make it up in the next session.
No.
Call me.
No, I think it was called for. I think that is hardly anything at all, considering the value of information delivered. So I'm not looking. Yeah, thank you, Bimla. Yeah.
And now we will be talking about the family planning aspect and COVID. And we all know that it is estimated that non-use of contraception in the current pandemic would be resulting into additional 7 million unintended pregnancies worldwide. And India, it is estimated that it would be additional 1.94 million unintended pregnancies. So this is an important topic. And we should be aware that sexual and reproductive health services are being severely impacted by the pandemic, and they must be prioritized. Provision of contraceptives, information, counseling, and services, including emergency contraception, is life-saving and should be continued during COVID-19 pandemic. So the next session will focus on maintaining continuum of family planning services during COVID-19. And for this, Dr. Shobha N. Goody, the chairperson of Family Welfare Committee of FOXI, is there. And I would request ma'am to please continue and enlighten us with the continuity of family planning services during COVID. Thank you. Over to you, Dr. Shobha.
Yeah, Thank you, Bimla, for that kind introduction. And I shall share my slides. Um, okay, just a moment. Yeah. Okay, are my slides seen?
Not
No,
yet.
I think this is whiteboard.
Is it seen?
No, Dr. Shobha.
Okay, just a minute. Okay. So what is seen actually? Only the
It's
now.
white screen, which is
Ma'am, it is whiteboard. Currently, it is whiteboard. So,
Just this one, na? This whiteboard. Okay.
this is whiteboard, ma'am.
Okay. Now I will share it again. Why
Yes,
is it coming like that? Any reason?
ma'am, because the first option is a whiteboard only when we start screen sharing.
अच्छा एक मिनट
So,
हाँ
उसके नीचे आएगा आपके
एक
presentation
मिनट
का.
एक मिनट एक मिनट okay okay next what I must do
Ma'am,
whiteboard
this is still white. No, ma'am. If you can stop share, please stop sharing. I'll guide you through it.
yeah okay
Now, ma'am, when you press on the share screen button, you'll see a basic, advanced, and files option. In the basic one, you'll have a whiteboard, and उसके नीचे ही आपका presentation अगर open है पीछे तो उसका वो photo दिखेगा.
फोटो तो दिख रहा है I have to
आप
share first ना
No, ma'am. उस पे आप click करें पहले उस photo पे and then share.
on the whiteboard I must click first ना
No, ma'am. On the photograph of the presentation.
अच्छा अभी दिख गया मेरे को okay now
हाँ, yes, ma'am. Now, अब इसको बस slide share कर दीजिए.
now it is okay
Yes, ma'am. Please continue.
thank you very much so that is me there and there is no need to go through this slide because I think by now most of you know me here I am present as chairperson family welfare committee from foxy I represent Dr. Alpesh Gandhi Dr. Jaideep Tank and Dr. Atul Ganatra who is the vice president and today I'm here to speak on the clinical aspects of FP services during the COVID pandemic. What has happened, what could have happened, and Khuda na khasta, if we face such a pandemic again, then probably we have learned a lot of lessons. We have to make most of those lessons in future. Let my time begin now, please. That is my request to you, Vimla. Though I promise that I will not take more than the allotted 20 minutes.
Sure.
Yeah. So this is what our direction should be towards enhancing the contraception prescriptions and practices in the pandemic, and that includes the counseling attendant to it and the follow-up attendant to it, everything together. So let me first say that it has been very, very tough overcoming barriers to contraceptive practice during COVID-19 in India. It has been a real onerous task, even so that FIGO COVID-19 resources and FIGO statement in the very beginning of pandemic had said that family planning, contraception services and supplies are core components of essential health services, and access to these services is a fundamental human right and they should be continued come what may. This has been endorsed by Foxy GCPR guidelines as well, which this team of Dr. Gandhi, Dr. Ganatra and Dr. Tank were instrumental in floating very, very early in March and April. There has been a series of 3 such GCPR guidelines guiding us through the management of SRH issues and pregnancy issues in COVID-19 infection. And all of them uniformly state that family planning services are essential services. And I hope that today clinicians are now aware about what is meant by essential. Though it may not be an emergency life saving, but it will be something which will prevent catastrophes and disasters. And we have to believe firmly that family planning is life saving. Unless we believe that family planning services are life saving, I think we will not be doing the best for our women. The barriers to sexual and reproductive health during and post COVID-19 have been several, but we do understand them as the lockdowns and the travel restrictions which so happened, and also the decreased access to the medical and the paramedical services, including the pharmacies. And this was well brought out in the Lancet publication. very early in the course of pandemic that there have been 26 million couples in India who have been unable to access contraception. And as Vimla was also saying, there will be an additional 2.3 million unintended pregnancies, and much of this has come to pass in the past few months. And there have been more number of unsafe abortions. And I've had personal feedback from my colleagues of women who have landed up in hospital in hypovolemic shock because their ectopic was unidentified, or because they have taken access to abortion pills across the counter, or they simply have had an unintended pregnancy resulting in a miscarriage because the contraception was not used, so on and so forth. Before we go on at all, it is worthwhile coming to perspective, coming to be informed that the 2019-20 FP indicators as which has emerged from the NHS 5 are already there. NHFS 5. The NHS 5 started before the pandemic. During the pandemic, the survey could not be conducted, and now it has been processed and released this month. In fact, we encountered it. We came face to face with these data on the 17th of December when the FPI decided to conduct an ARC meeting, and we participated in that. And we saw that 22 states' data has already come. So 12 parameters of FP indicators were flashed, and this is what we saw, that this is the current status before the pandemic. And we can see that there has been considerable improvement in several parameters of contraception prevalence rate in several of the states have gone beyond 65%, which is extremely good. And the unmet need total has been coming down in several states. The unmet need spacing, the highlighted in red, are the ones which have not shown improvement, and you can see that they are far and few in between. And few states like the northeastern Mizoram and Meghalaya are showing higher indices, and of course the island states of Andaman Nicobar and such like Ladakh, etc. They do show some high figures, but by and large, this was something that we would have tapped ourselves on our back for having done a good job. But then the pandemic has intervened, and much of these data, once it is processed to the current one, will show a difference. Well, why is providing contraception FP as well as all other services related is important? Of course, it is because access to effective contraception is a very, very cost-effective intervention to reduce maternal mortality through preventing unintended pregnancy and the complications thereof, and reduce the total burden on the healthcare system of the country. Do Indian women receive adequate information about contraception? This is a very well researched data from the previous NFHs, the fourth one, and this itself had shown that there is a lot of lacuna about giving adequate information to women on this service. The method information index is only 31%. The fact that sterilization is a permanent method is known by only 80% of the client who receive it. Healthcare worker who ever talk to women who are non-users, do they get spoken about FP? No, only 18% of them get spoken. Current users, are they told about side effects? Only 34%. So this should be almost 80 to 90%, so the discontinuation rates can be brought down. The provision of services is seriously impacted in the pandemic. Well, that has been well brought out by this FRSH survey, which showed effectively that injectable contraceptives saw a decline of more than one-third prescriptions. A fifth of IUD insertions came down, and so on and so forth. There was also a 28% reduction in the abortions performed, which, according to me, is the highest concern, because this is one index of failure and one predictor of mortality and morbidity. So this is how it has been. Up to 26 million couples, as you rightly said, Dr. Vimla, in India may face an unmet need, and much of it has come to pass. So, and we were not able to do that greatly to avoid these, and we might have seen the worst case scenarios of 27 million and not the best case of 24 million as was predicted. The number of unsafe abortion also is close to 1 million rather than 6,81,000. So this is how things have come to pass, and some of it could have been at least avoided. So women might ask us what is the best contraceptive method during the COVID-19 infection. We can very assuredly tell them that all modern methods are safe actually, unless they have medical comorbidities like being diabetic, hypertensive, having sex steroid sensitive cancers, or if they are smokers, then they will require for contraception prescriptions which are in complex situations a face consultation. But otherwise, I think teleconsultation will be a great option for these women who seek contraceptive advice. So this has been spoken just now in great detail. I just wanted to tell you that the concept of telemedicine and teleconsultation has been maximally utilized for the service of contraception. And the simple reason being that most women who are well enough to receive contraception services. So, well women rather would prefer to use the platform rather than attending hospitals, because actually they are not feeling sick or unwell, and therefore this was the maximally utilized service over teleconsultation. And rightly everything has been told about that certification is not needed as of now till the certification process guideline comes. And it is also very evident that most FP services can be provided on a virtual platform, which could be audio or audio visual, especially the emergency contraception, especially the refill prescriptions for COCs or subcutaneous MPA. And COCs can be very well given as a refill if in the past 1 year she has had her BMI and BP checked, which is known to be normal. The suitable contraception method queries can be addressed in different life situations of post-abortal, postpartum, newly married situations, or unmarried situations, or adolescents. And we can promote extended LARC concept. LARC are long-acting reversible contraceptive methods, which include the copper IUCDs, the implants, and the levonorgestrel intrauterine system. And we can see here that instead of functioning for 10 years, the 380A can function for 12 years, implant can function for 4 instead of 3, and LNG for 6 instead of 5 years. And the woman need not come rushing to the hospital to get it removed and reinserted, because the contraception extends, and hopefully it covers the pandemic time. The exceptions, of course, are copper IUCDs of 250 and 375, which function for 3 to 5 years. Beyond that, there may not be any need to come rushing to get it removed, but of course, teleconsultation can be used to prescribe alternatives, add-on methods to protect the woman from pregnancy. When do we convert teleconsultation to a visit? This is an important, step to understand that if a woman has these situations, she needs to report to the hospital or the clinic. If there is pain, if there is suspected pregnancy, if there is a request for abortion, if there is menstrual disturbance, if there is complex situations, not only medical disorders, but disabled women or LGBT or commercial sex workers, or there is sexual abuse or assault, etc., or there are post-procedure complications after having given a service, or there is suspected STI, which is very, very important. Okay, so in these situations, the woman needs to come for just a moment. Yeah. I'm sorry, I'm not able to move it. I hope, yeah. The scope of teleconsultation has been already discussed. The category O, A, and B very well fit in with contraceptive services, as I've already told you. An important category O is, of course, the emergency contraceptive, but never the abortion medication. Refills I have discussed, and add-on is for troubleshooting of intermenstrual bleeding, etc. Client requesting sterilization. So should sterilizations be postponed? This is what happened in the beginning of pandemic, but as early as June 2020, the government of India themselves said that no, sterilization should not be postponed, should be provided. And if it so happens that it cannot be done due to any reason, then we must push towards LARC and convert that request into a LARC method, because in fact, they have got the equivalent failure rate as a sterilization. This has been endorsed by several publications, and one of them is by this group, Kavita Nanda et al., and continue to offer insertion of LARC methods to new users where possible with adequate safety preparations for the procedure. So a copper IUCD insertion with a PPE kit will give her safety from pregnancy for the next 3, 5, 10 years, and that is worth doing. Program implementation is something we all need to be sensitive about, because today Foxy well understands that one consultant alone cannot provide an FP service. There has to be a program which covers eligible couples, increases the use of digital platforms, ensures supply lines in the pharmacies, relaxes restrictions on the number of repeat issues or prescriptions, and ensures access to EC at all times, over the counter, and immediate postpartum and post abortion. These are critical periods which should be considered as very, very special situations where we cannot afford to lose the chance to bring in contraception use. Policies by the head of the hospitals also have matched up, should match up in the times of pandemic, to give effective telehealth consultation process in place in the hospital, and information should be given correctly from the hospital to the clients, including maintaining an electronic medical register and giving them warning messages that their time for refill or change of device is coming close, monitor for any potential shortage, and increase the availability. And of course we need to document and audit our work. I think these things are what has been covered in the teleconsultation, but already I have also covered that a lot of these services should be in. I think this is from Dr. Walke's presentation, so I will not take that. This is one case. I will quickly go through 2 or 3 cases just to drive the point home. She is a 22-year-old para 1, delivered 6 weeks back by cesarean, but she presents as an engorged breast, and she is presently breastfeeding. So how to help this lady? She also seeks contraception advice, and she has called us up actually on the phone. We give her good consult for relief of the breast engorgement. We also tell her the importance of contraception, and there will be a large basket which can be created here, because this is postpartum situation, and she will be eligible for injectables, for the progesterone only pills, for the intrauterine devices, for the barrier methods, and also for natural family planning method. Of course, LAM can be in place, lactation amenorrhea, but this woman will require a high level of counseling for LAM, because she is a techie and she has already reported with engorgement, which to some extent tells us that she may not be practicing LAM. This is another challenge, an adolescent who is just 18, so she comes out of the POXO Act and can be told about contraception, obese and has acne, some features of hyperandrogenism, therefore, and she will merit again a basket of choice, which includes the low dose oral contraceptive pills, the combined ones, in addition to dual method like emergency contraception and barriers also. She can also go in for one of the LARC methods. Please remember that nulliparous, unmarried, young girls also can be fitted with devices and can be provided with implants. There is no problem about their non-provision of service. Their LARC is equally suitable for young girls. They are in socially insecure relationship, all the more that we need to be sensitive. 37-year-old who has got 3 cesareans, has medical disorders, and is requesting sterilization. Of course, this is a situation where the husband can be advised to do a vasectomy, because this lady already has a difficult surgery, but otherwise it can be provided. If cannot be converted to LARC, it can be provided in a tertiary care with better facilities and the consent, that if we are for some reason unable to access the tubes because of adhesions, we might do a LARC insertion at that time. A woman requesting for for abortion, what can be done in the times of pandemic. The entire consult for abortion can be condensed into a single visit to the clinic, wherein the prescription for medical method of abortion can be given to her. So these are the type of services that should be continued in the time of pandemic. I shall just go forward a little so that we can deal with this large number of institutional deliveries. We often say that that India has got 26 million deliveries per year, 26 to 27 million deliveries per year, and there is a huge onus on the healthcare system because of these deliveries. Should we call them as 26 million deliveries, or should we call them as 26 million opportunities to put in postpartum family planning in place? And one of the best methods would be a postpartum IUCD, and that which can be determined even during the antenatal care whenever she comes, either online on the teleconsult, or when she comes, and to take her consent on a seal like this, wherein we can determine earlier itself that the woman has consented for the PPIUCD. And there are very few contraindications to placement of a postpartum IUCD. The category 4 only tells about these 3 situations of infection and unresolved hemorrhage, and also category 3 is between 48 hours and 4 weeks of delivery, so that is very easy to remember. Category 2 is not greatly identified. Category 3 also says if there is prolonged rupture of membrane more than 18 hours, gives the relative context for the setting of infection. And category 1 is all the other women who have not been described here. So that is a large population which can be covered, and if adequately counseled, copper IUCD in the postpartum period, post-placental period, or intracesarean could be our solution for population stabilization. I think I do not have enough time to go through the rest of my slides, but this is a slide to show that copper IUCD is also very, very suitable for women who have a large number of these medical disorders are listed here. So women who are not otherwise well can also be sourced this method of contraception. It is very, very safe. They come under MEC category 1 or 2. You can see the listing there. So let me go ahead of this. I think I should end my talk with EC and with integrated care. I must tell you that women who, or couples who report in a panic because they have had a UPSI and unprotected sexual intercourse or a break of condom, should be offered a basket of emergency contraception, because EC is no longer a single method. It means you can give her an LNG pill, you can give her a ulipristal acetate, you can call her for a copper T insertion, and also you can advise her to come so that you can check her up, put in a copper IUCD and take it forward. The USP's method of 2 tablets of OC pills BID can also be given to her. So the emergency contraception service in the pandemic is no longer just a information or prescription for a method, but it also means that we have to perform the quick start contraception with these women. We have to pre-arrange the collection of EC pills in case that they fail to take up the additional contraception. You have to arrange emergency IUCD insertion, and you have to provide advanced prescriptions of all the methods which we have just now discussed. So we need to also be very adept at ruling out pregnancy, even if it is on the teleconsult. So this is a WHO listing of how to rule out pregnancy. GOI also endorses this, that if a woman says yes to any of these questions, she is unlikely to be pregnant. And then offer her a quick start contraception of any of the methods. She has not had intercourse since the start of her LMP. She has been correctly, consistently using a reliable method. She's within 5 days of onset of a normal period, less than 21 days postpartum, fully breastfeeding, amenorrheic, less than 6 months postpartum. That is, she is following the LAM method. She is within within the first 5 days of the abortion, miscarriage, ectopic pregnancy, etc., she's not had intercourse for more than 21 days and has a negative pregnancy test. So these are the, if she says yes to any of these, she's unlikely to
We
be.
are running out of
Yeah.
time. So
So I end with my message for integrated care for family planning. And this is the concept of eye care clinic, which should be, established in every private setup. That is our thought, because the government already has its own, family planning units. So we feel integrated contraceptive care approach for reproductive age, across reproductive age, should be our concept. And we need to have centers inside or a cubicle on the OPD floor where a trained counselor can be present to give the gather approach. And in addition to the consultant's basket of choice, a trained counselor will be able to help. This service can also be digitized. So I end with these closing remarks that during the pandemic, these are the points which need to be taken care by any maternity unit, and that there should be no supply side constraints of contraceptive methods. A database of the target population should always be available on an EMR so that clients can be accessed at any point of time. Knowledge gap needs to be filled. Ways of digitization should open up. We need to create an agency for women. They should come forward and ask for contraception. Demand generation, in fact, is the key to our problems. Changing the conversation and talking more and more about contraception will help. Cross linkages like what we are experiencing today, collaborations with the reputable statutory authorities, and creating platforms for research and training will take us a long way. Elementary concerns will still persist, and they are the ones which indicate about myths, misconceptions, and not only the woman's minds but her partners and her families who resist contraception. Women need to be convinced from within that this is a value add on for her health. Demand generation is crucial and partnerships are essential. On that note, thank you very much. I'm very sorry if I have taken extra time. Thank you.
thank you, Dr. Shobha, and it was a great presentation on continuity of family planning services. Now I invite Dr. Rimpi, who is Assistant Professor at PGI Chandigarh, and she will be discussing about the abortion, the pandemic, in the context of COVID-19 pandemic, how the abortion services are to be continued and what has been the experience of that. Dr. Rimpi, over to you. And I would request you to kindly, time is a limit with us. We have a panel also, we have to take some questions. So please be brief in your presentation if possible. Thank you.
Thank you, ma'am. Am I audible and slides visible?
Yes, yes.
So I'll be talking about abortion services during this COVID-19 pandemic. And to begin with, I would like to highlight that this study in 2015, it showed that 15 million abortions occurred in India, and out of these, 78% occurred outside healthcare facility. And out of these, 5% were done by unsafe methods. Well, this was a scenario much before the onset of pandemic. But with the onset of pandemic right in the beginning, this anticipation came up in April only, that in low middle income countries, even with the decline of 10% usage of contraceptive, we expect 15 million additional unintended pregnancies. And when patients do not have access to safe abortion, so even if there is 10% shift of abortion to the unsafe side, that will amount to at least 3 million additional unsafe abortions. So it was expected that this was the likely scenario as presented by Madam, that it was expected that we will be having around 2.38 million unintended pregnancies. And if we extrapolate the data of 1.45 expected million of 1.45 million abortions, so around 800,000 unsafe abortions were expected. So now, why I'm saying that, because with the onset of COVID pandemic, because there is unplanned pregnancies are there, and they are going to increase. Why? Because mainly because of barriers to access the effective contraception,
And another thing is that the sexual activity is not going to cease, rather increase stay at home and increase intimate partner violence that can be extrapolated to increase in the unplanned pregnancies. Now, once we have unplanned pregnancies increasing, we want access to safe abortion. But that was expected to decrease because lack of transport services, loss of income, movements being restricted. So all these things were expected. Now, to make the matters worse, some countries, they took the advantage of this COVID pandemic. The countries where the abortion services were already very much restricted, they even attempted to exploit this pandemic, and they declared the abortion services to be non-essential, including 13 states in US itself. So what happens? One must understand this thing, that even if abortion is denied, it is just going to convert from safe to unsafe. The number of abortions are not going to reduce. As in this study, it was shown that 87% of the abortions in legally permissive countries are safe, and whereas in legally restricted countries, only 25% abortions are safe, and 31% were done by least safe methods. Now, another, this is my favorite diagram that shows that in the legally permissive countries where the laws are, their laws are, they allow abortion even on request, the abortion related deaths are very low, whereas where the laws are very strict, the abortion related mortality is very high. So consequences, we know, very high mortality rate, 9 to 20% of maternal deaths are accounted by unsafe abortions. So it should be understood that safe abortion is an extremely time sensitive essential healthcare and should not be denied and should not be delayed. And because the legal gestation limit for abortion may not permit any delay, mortality and morbidity of abortion increases exponentially for each week added to the pregnancy. And second trimester abortions are definitely have higher risk than the first trimester abortions. And delaying the abortion by declaring them as non-essential services, what it will lead to? If we don't do the abortion, it will lead to the increase in pressure, increased pressure on the existing resources, because now the women will need to continue to follow up in the pregnancy, and then will need to care for her delivery and the postpartum period and for the neonate also. So by any means, it is like if we curtail the abortion services, we are not going to reduce the pressure on existing services, rather it is going to increase. So abortion should not have been declared by as non-essential services anywhere. So they are essential. So ACOG right in the beginning, it said that they do not support any COVID-19 response that cancel or delay the abortion processes. So India has listed this as essential services right in the beginning. So we have been providing abortion services, and what has Ministry of Health has done, they initially in the beginning of pandemic only, they mapped out the existing facilities in the public, non-profit and private sectors, and the facilities and the separate blocks within facilities, they were marked for the COVID care and for non-COVID care. And thankfully, they listed the medical surgical abortion, including the post-abortion care and contraception, to be, they ensure that appropriate facility level that they should be provided to all the women who require them. Now, but the problem doesn't end here. With these things, the problems were still there, like because many facilities were designated towards COVID-19, so there were definitely crunch of the healthcare facilities. There was definitely crunch on the staff also because of the closure of private health facilities, because they were not having enough resources to support the services. And in the public sector, the many of the staff members, they were like deployed to the COVID-19 duties. So definitely we had understaffing. We have less of staff catering to the abortion services in non-pandemic era also. But this is going to further exacerbate. Like now again, we have got the most of the staff, much of the staff is diverted toward the COVID-19 care. So when there is delay in abortion, so then the patient might approach in the second trimester. And for second trimester, again, the services are even more restricted. And disruption in the supply chain is another factor. At the patient level, patient might be, cautious about visiting the healthcare facility because of the fear of contract COVID-19. And when during the complete lockdown, there was suspension of transport services, and the socioeconomic status was also important, that affected the abortion services. And the worst hit were those people who were like migrants and poor people, refugees and adolescents and vulnerable women. They were at even more fear of having unsafe abortions. So this study, this came up in August 2020, like 5 months of the onset of pandemic, where Mary Stopes International, they recorded response of 1,000 women, and they found that 13 lakh women could not access any kind of sexual reproductive health services. And from January to June, 9.2 lakh women in India estimated to require abortion services, but they could not access it. And this is another study done by IPAS. They built up some model. On the basis of those model, they calculated that, and out of 3.2 million people who were women who wanted to have abortion, 1.85 million could not access to the services. So it was compromised. And they found out that this was based on a model, and then they called up the healthcare facilities also. They did a survey, and then they found that the maximum impact was on the initial period of lockdown when it was a strict one. The 59% was at that time. And as the relaxation occurred in the lockdown, so gradually the abortion services, gradually the access to the SRA services also improved. So why this, out of these 1.85 million abortions that were compromised, so they say 80% has been because of decrease of sales of the abortion drugs, because as in my first slide, I said that most of the abortions are being provided by the facilities outside the designated healthcare facilities. And these were the worst hit. And 20% of the remaining, it goes to the healthcare facility-based abortions. So it is because of these two factors, they anticipated like 1.8, they calculated 1.85 million women were denied of abortions. So what does the woman is left with after she's denied of abortion because of all these factors? Either she will have to finally access, but next she will be landing up in the second trimester. She might resort to medical abortion outside the facility. She might need to go to the surgical abortions, or might have to continue with the unintended pregnancy, or would resort to unsafe method. Now, it has been documented in one study that many gynecologists were like, and many people, they were forced to, switch from the medical to surgical abortion just because of non-availability of services that led to delay in the abortion services. So the key of enhancing access lies in telemedicine, as has been discussed adequately, and the medical method of abortion will be the mainstay of ensuring access to the safe abortion services. Another thing is not being demanding on the consent or the presence of spouse, because this is actually not required by our MTP Act also. And digital platforms should be used to educate the people. There has been survey where it has been shown that many women, they didn't even know that abortion services are still being provided. Many people think that now the healthcare facilities are meant only for the COVID patients or the sick ones. And next is the relaxation in policies. So WHO also recommends that women can safely manage abortion at home, provided they have got appropriate information and they can access the healthcare facility whenever they have any problem. At any stage of process, they should be able to access the healthcare facility. And regarding the safety of this medical abortion, this is the evidence from this study where it was shown that the sales of mifepristone in India were around 12 to 13 million in a year, but number of reported abortions were much less than that. So, considering this fact, to say the already the use of mifemizo is already very high, and very severe complications are really less. So, provided under the supervision, provided under the care of a provider, where you rule out the contraindications, then you can prescribe for home-based management. So UK has devised this model where they're thinking that the women can safely and effectively have abortion with mifemizo when they have accurate information about the dosing regime and they know where to seek any if there is any problem. So what is their model that whenever the women request abortion, the remote consultation is offered through phone or video, and then all the eligibility is assessed through telephone call only, where all the information is sought from the women, and then they are like assessed whether they are eligible for the first trimester abortion, and then the medicines, they are dispatched by post, or they can come and somebody can come and collect. And additionally, they are also provided medicine for like analgesia and antiemetic also, and written information and advice is provided, and further follow-up is also done remote through telephone. Now, the advantage of telemedicine in abortion services, it overcomes some of the most substantial barriers that were existing even before the onset of COVID pandemic. It enables women to access care at home, thereby preventing them from having to travel and preventing their exposure of COVID-19. It protects the healthcare providers also, and it found to be safe and effective and acceptable to women. And but most important, it ensures timely access. So India has got a hybrid model that is the stable one, and in this the teleconsultation services should be utilized to take history, counseling of the patient, and advising investigation if required before the prescription. But for actual prescription, we need non-virtual consultation because we need consent also. We need to examine also. So right now we are not prescribing the MTP kit online and through teleconsultation. All when she comes to the hospital, then all precautions need to be taken, and medical method should be the most commonly used method should be provided until unless it is contraindicated. So this with this, these are the guidelines for otherwise the abortion care in routine also. For pre-abortion, the detailed history and everything can be sought on phone on the telemedicine also. And the women, when she presents, she should be screened for the symptoms of COVID-19. Gestational age can be estimated by LMP and examination. Rarely you need to perform an ultrasound before giving abortion services because most of especially if the woman is able to tell you the LMP with a reasonable certainty, and in case there is any disparity in examination finding, you can order for ultrasound, or if there is any doubt of ectopic pregnancy, then also, or otherwise second trimester abortion in case of previous cesarean, then we sometimes the clinicians they desire for an ultrasound. Other than that, just for the estimation of dating, ultrasound is usually not required if examination and history are reliable enough. Investigation, basically it is said by WHO that routine lab testing is not a prerequisite for abortion services. However, hemoglobin and blood group and urine analysis are the basic investigation that we are doing, and HIV counseling and cervical cancer screening is offered. And but these are not mandatory as a prerequisite for abortion. If the woman is not showing any signs like pallor or anything, we can go ahead with abortion services if there is no other contraindication, no other known medical disorder. And information and counseling is utmost important, and you have to tell the patient what she is likely to experience and how what pain management options should be discussed, how long it is going to last, and most important, what, when, and how she should approach the healthcare facility if there is any problem. So these are the WHO regimes. They are very crisp, very clear, crystal clear, that less than 12 weeks, the regime is mifepristone 200 milligram, followed by 1 to 2 days later by 800 microgram vaginal misoprostol or sublingual or buccal. And for more than 12 weeks, 200 mifi, followed 1 to 2 days later by 400 microgram vaginally or sublingual or buccal misoprostol, to be repeated 3 hourly. Now,
important is 5 minutes now.
Okay, I think I'll be able to get through. Yeah. And for follow-up, they say that mifi-meso method, the combined method, is so effective that you actually mostly it is like complete. You don't need to follow up the women to check for the ongoing pregnancy. If the women give history of expulsion of products, then it is fairly reasonable to assume that the abortion process has been completed. And contraception counseling can be done right at the beginning while you're giving the medical management. Most of the hormonal methods can be started with the mifi-meso itself, and IUD placement can be done once the abortion process is completed. Now, for the women who are self-isolating, if it is suitable for early medical abortion, then you can provide her through teleconsultation. You can assess the eligibility, and then better to book when the isolation period is over, but if it doesn't cross the legal limit. If it is anticipated that she'll cross the legal limit, then it is best to call her, and with proper in the facility where COVID-19 precautions are, the prevention measures are in place. If the woman is suspected or confirmed to have COVID-19, if she has tested positive, then the risk assessment should be undertaken and decide if the abortion can be safely deferred for isolation time. If not, then she has to be called to a center which is equipped to manage the COVID-19 patient. Now, important, if the woman has symptoms, now her medical disorder becomes a priority. Admit and treat in the facility that is equipped to manage the COVID-19 patients. She should be assessed clinically and then the book for at least 7 days since the onset of her illness. The best method will be depending upon after discussion with the other facilities like infectious disease team and the anesthesia team. For complex cases, we have to have a multidisciplinary approach. So the main important message is that for the women who are symptomatic for COVID-19 or they have confirmed infection, it is best to delay the abortion until she has recovered and are no longer infectious wherever possible. So in surgical method, avoid general anesthesia, that is most important. And I'll quickly run through the most important one is like, yeah, where some people are make this COVID-19, this is presenting itself as an opportunity to make self-managed abortion as a new norm, and telemedicine, which has been promoted to support delivery of healthcare services during COVID-19. As Dr. Dilip has said, it may be a long-term opportunity to safeguard every person's sexual and reproductive rights well into future also. So the global policy is like many people, many countries, they have shifted temporarily from for telemedicine for first trimester abortion also, and they have removed the legal requirement of the women to attend the clinic, and they are posting the pills also by post, and they have increased the gestation limit at which the women can administer the abortion at home from 7 to 9 weeks. This is a global scenario, and this is a study done by IPPF where they have shown that many countries who started with COVID this telemedicine services to enhance the abortion services. Now they are all of them are planning to extend these services well beyond the pandemic into the regular practice also.
2 minutes,
And
Dr.
yeah,
Wimpy.
ma'am, this is my last slide. So, but there are barriers that have to be recognized. Number one, the telemedicine, including the problem is that some countries are still having ban on the provision of abortion services through telemedicine. They are still blocking the websites also. And important thing, these are relevant to India also, that only the registered medical practitioner, only the sites, designated sites can offer the abortion services, not everywhere. So home-based management of abortion, it's still not permissible here. And some countries advise that one or two, both the medicine have to be taken in the presence of a clinician only. And somewhere it is, some places it's like only OBGYN doctor only can prescribe these medicines. And some countries demand the ultrasound to be mandatory, and mandatory written consent is also perceived as a barrier. And at the women's level, access to internet is an important issue, and that many people, they do not know that the abortion services are legal, and there is a shift in the change there is a change in policies that to enhance the access. So with this, I would like to thank you all.
Thank you, Dr. Rimpi, and it was very informative and so many new things you have updated on telemedicine and abortion. Thank you so much. Now the next part of the CME is a panel discussion, and for this, in addition to other panel members, I would invite Dr. Srinivas Gadappa to be the panel member, and we will have a round of questions. Dr. Srinivas Gadappa is from JMCH Aurangabad. He is professor and head of department of OBGYN department. So welcome Dr. Gadappa to the CME, and thank you for joining. I hope we are audible to you, and
Yes.
Thank you. So we will I'm taking some questions which to each of the panel members. And the first question is to Dr. Bharti Joshi. Dr. Bharti Joshi, are you still there?
Yes, no, I'm there only. Hello.
So the question is, what has been the impact of COVID-19 on healthcare providers working in the labor rooms? So in your experience at your facility, what has been the experience?
When in the beginning, definitely we had a lot of confusion. Actually, because there was 3S we need to dealt with. First was staff, supplies, and then space also, because we need to create a space for the suspect or COVID positive patients. We need a mobilization of staff for taking care of such patients, and supplies, which was one of the utmost important, because we needed protective gear. So we need to take care all these things, staff, supplies, and space. So definitely in the beginning, because ICMR also has a stringent criteria for testing of everything, so we have a limited supply of kits also. So first of all, our residents, they were not well trained, so we had a difficulty in getting all the protective gears. We had a difficulty in training in the beginning, and there was a lack of communication, because whenever you are donned, actually you cannot conversate with your colleague. And whenever emergency is there in OT, definitely we have to use a sign language to communicate with sisters, to communicate with HA, SA, and to get something. And for the positive patients, we have to establish different laboratories, different blood bank system, so that the things are not infected with the general pool. So in the beginning, we have to develop, we developed the protocols in place that kept on changing, because we had a different guidelines, updated guidelines. And the things become little easy after 2 months, when we get a lot of protective gears, and ICMR made a criteria that all the pregnant females has to be tested, and even a high risk contact worker can be tested, and we got a lot of kits. After that, all of us become relaxed, because the moment I am have a high risk contact with some person, I go and get myself tested. Otherwise, most of the time what we were doing, that we were quarantined our residents for 14 days, because we didn't have the system to test these residents. And definitely we have a shortage of supply. And then we segregated the workplace. First, we used to have a 2 labor rooms for the infected ones and for the clean ones. But now we have a 3 labor rooms at least. First is walk-in patients, that is a suspect room. If the patient is negative, move to the clean labor room, positive, move to the COVID wing. And definitely residents are also working in different areas. So they have a shift of 8 hours now, because they have to wear that protective gears for that time. So all these difficulties we faced in the early, but now the things are little streamlined, because everything is now in place. We have a different COVID wing. We have a big separate suspect labor room. We have a suspect OT also. But still, for managing emergencies, we face difficulties, because every time patient come, this is that exposure to that patient is a time consuming. We have to wear our at least face protection, we have to wear gloves, and sometimes we have to rush to the OT. But at that time we have to take some 15 to 20 minutes extra for wearing, for donning and doffing, and we have to create some area the doffing also. So these were our work experiences. But now we personally feel that up to 70% of the cases, or the 70% of the load is back, and we are able to streamline, and we have developed protocols in place. And till date, we have managed almost 165 pregnancies, and all the pregnancies.
Bharti, I think that was discussed in your presentation also.
Yes.
And
Yes.
that was like the management at Chandigarh PGI was very well managed.
Yes.
So
Yes.
I will come back to you. And now I move to Dr. Gadappa. He has also experience of working in the medical college. And the question to him is how to ensure respectful maternity care in labor room during COVID-19 pandemic, and the role of birth companion and labor analgesia, because this is a challenge to have a birth companion during COVID and COVID positive. So Dr. Gadappa, what has been your experience of on this?
Thank you for involving me in the panel, Dr. Shobha Kudi madam. Thank you very much for involving in this. The question is that birth accompanying during labor. Normally, when we are ensuring respectful maternity care, birth companion is a big question, and that too in COVID, it will be a double question. So initially, it was very difficult for us because our medical college Aurangabad is practicing respectful maternity care, where we are providing birth companion to all. But once the COVID is declared, then it was lot of panic situation was there, because there were no guidelines, testing was not adequately available, even the suspicion of case and the case suspect was also dilemmatic. So initially the healthcare providers, and that to staff sisters and doctors, were reluctant to have birth companion in labor room. So for 15 days, there was no birth companion in labor room, but gradually the protective measures come, protective gears come, then the testing is available. Then as previous speaker said, there were 3 labor rooms. One is suspect, another is a positive, and another is a negative. But now with this motivation of the healthcare providers and the protective gear, their mind was changed to have the birth companion. But when the birth companion in non-COVID labor room was very easy, because these women were screened and they were labeled that they are not having a corona disease. So birth companion putting in this non-COVID labor room was easy. But in a suspected and in a positive cases it was difficult, because the one positive thing in the negative is that the COVID patient, due to the COVID era, the number of patients turning to the medical college were decreased. We have almost 40% decrease in the delivery rate. So those who were positive, their relatives are concealed and even they are tested, and then they are given a protective gear. So those who are willing to have a birth companion, they are allowed. Most of them, they were reluctant to get a birth companion. The woman herself has denied, and the relative. So 20 to 30% birth companion is possible when COVID positive is there.
So that was the protocol you were following for all the clients, and you ensured that respectful maternity care was delivered to them during COVID time also. Thank you, Dr. Gadappa. Now I would come to Dr. Dilip, and I have two questions for you, Dr. Dilip. One is, how can we promote more patients uh, as well as service providers to use the teleconsultation platform in the future, because this is a new upcoming area which we are exploring, and what are the medical legal issues that we come across while providing teleconsultation services? Some of the aspects which have I think touched during the presentation, but Dr. Dilip, if you could add on these aspects as well.
The first barrier, I must say, for teleconsultation were the doctors themselves. I mean, many of our teachers would just not accept the fact that you can do some consultation without having examined the patient. And I'm very happy that there are many teachers here, because initially I was promoting teleconsultation even before 25th of March 2020. For last 2 years now, I had my app 2 years back. But whenever I gave a talk on teleconsultation, I used to be really wooed out. I mean, everybody used to just pounce on me saying that this is just not done. So the first barrier has already crossed. We have crossed that barrier, that now most of our teachers are okay with doing teleconsultations for abortion services, for ANC and PNC. We have passed the first barrier. Now, the second thing would be to make it more popular by having more such interactive sessions where the doctors are attending. And it will not be just enough to enlighten the doctor on the legal aspect, but it will be important for us to reach out to our patients also. So many of these private platform providers are now going to do some marketing. A day is going to come when the telemedicine platform providers will start earning a lot. They will come on televisions, they'll come on YouTube, and they'll come on social media, and they'll start advertising also. I hope I make enough money so that I can start advertising on a channel. And when I do that, then there will be many people who will be aware of teleconsultation, and this will actually go up.
Thank you, Dr. Dilip. Dr. Shobha, I would like to ask you the next question. And the question is, although GOI has made family planning services essential services, but very few elective services are available till now. And I want to know, how can FOXY and the private sector help in improving the accessibility of services, especially like sterilization, tubectomy services, and interval IUCDs. We saw teleconsultation for other contraceptives, but yes, the permanent method and the LARC IUCD has been affected a lot. So what can be the role of FOXY in that?
Yeah, I think that's a very strong aspect that you have touched, and need of the hour, because the LAPM, long-acting and permanent methods, need to be propagated, especially in the times of pandemic. And the same was indicated by the NFHS also, the latest survey data. LAPM methods, already the services resumed in the month of June. There is some problem about demand generation and clients' need, because they have tried, the clients or the pregnant women, the postpartum, the post-abortal, all of them have not understood as of now that how important the family planning services are. So FOXY has consistently made effort with the social media also to say that these are essential services and they are available 24/7, because that is one thought in the patient's mind, that none of these services will be available. So we have made it a point to make a very big noise about it, that these are essential services. These are essential services. So also has FIGO. So that is the first thing which we did through our programs and through social media. That is the first thing. The second thing is to see that the supply chain and the consultant services are uninterrupted, and that is where the teleconsultation has come forward in a big way. The supply chain also, luckily for the past few 2 or 3 months, has lot of the supply problems have been sorted out, and the stocks have been replenished in majority of the states. I will not say most of the states. Probably where the second and third wave was experienced, there still the supply line may be deficient. But then, for example, in the state of Karnataka, we have had access to all the methods for the past 2 or 3 months. Having said that, the huge gap of knowledge about contraception and its safety still remains a very huge problem to overcome. And our next efforts in the next 6 months will be towards demand generation, and we are hoping to achieve something with our strategies. Thank you so much.
Thank you, Dr. Shobha, and thank you, Foxy, for keeping the FP agenda in its in their high in agenda. And thank you for your leadership on that. And now the question to Dr. Rimpi is on abortion. Like, can you throw some light how medical abortions can be provided through teleconsultation legally? Because there is a legality angle as well when we say abortion services. So how the teleconsultation can be legally provided, provide medical abortions, and do you see more complications related to unsafe abortions due to reduced accessibility to safe abortions during COVID pandemic? So Dr. Rimpi, over to you.
As I said in the presentation also, India is still having a hybrid kind of model where we do offer telemedicine consultations to assess the eligibility, to assess any medical disorders, to assess the gestational age and all that. And many times the patient has got ultrasound or hemoglobin basic tests done, and we can order them on, they can be WhatsApp, they can be sent to us. Till the consultation history taking, it's fine. But our law still demands written consent to be there, and that has to be there. And we still do not have any policy saying that we can deliver MIFI and MISO on by telephonically. We cannot advise them that just go and have. We still are in PJ also. We do offer teleconsultation, but for actual delivery of medicine, we do call the patient to the hospital and give under supervision only, ma'am. And for like 7 weeks, 8 weeks, we give the medicine, and for the mesoprostol I'm talking, and she goes back home after half an hour, 1 hour. But for advanced, so more than that, like 9, 10 weeks, like we prefer to keep the patient for more time under observation, and then we send. Then obviously we need to screen the patients. These things are there, but absolutely through telemedicine providing the services, it is still not the norm here, ma'am.
Thank you, Dr. Rimpi. And one of the important things about family planning and also MNCH services is the trend of utilization we observed during the COVID pandemic. So, Dr. Kadappa, can you throw some light on what is the trend of utilization of MNCH services, including FP services during this pandemic?
In pandemic, actually, due to the lack of transportation and lockdown, the number of patients turning for family planning services were very less. But the other problem was that our being a tertiary care center, it is COVID and non-COVID hospital was declared, and most of the peripheral hospital, the facilities were there, they were not giving treatment for family planning services. Either they were busy in treating the patients of COVID, or they are deputed somewhere. So overall, the number of patients attending to our hospital is less, but the required patient who require family services are more. So those women who were coming to us, they were given a family planning services in the form of abortion and surgical thing. But home administration of misoprostol we have not tried, because the women who are coming to us, they are from rural area. Sometimes the mobile communication is not with them. So those patients were admitted, and then they were given a surgical method of abortion. In this era, we got more mid-trimester MTPs, that is, the crossed first trimester. So this was a major issue, and these patients were again addressed here. And most of the patients, they came with direct bleeding PV with incomplete abortion, because they tried some form of abortion field outside. So this was a problem in the COVID era.
Thank you. Thank you, Dr. Gadappa. There are a few questions from participants' end, and there are 3 questions in fact, and any one of you can just take these questions. The first question is from Dr. Shiba Marwa, and she asks, what's the biggest evidence you advocate for the effect of COVID-19 in pregnancy? Do you have your own data? If please share the results. I think this is for Dr. Bharti. If Dr. Bharti is there,
Yes,
can
yes,
you
yes, ma'am.
please answer
Ma'am,
the
I think I
question?
have already quoted that it is published in September last and October first week. That is in BMJ. It is a systematic analysis and involving 11,000 almost more than 500, 11,500 females. So they have compiled all the case series, cohort studies, and comparative data is also there comparing with the non-pregnant women of the almost same age and gestation. So this is the biggest data we have so far, but we have another articles in AGOGs and scientific journals. They have quoted around 1,100, 1,500 women's pregnancy. And I think our data, we have already shared the experience that I've already said 165 females, and 95% of them were asymptomatic. Only 2 patients of us, they were category B, where we used DEXA steroids for their recovery. These both patients have a COVID pneumonia. They have a ground glass opacities on CT scan and X-ray, and one of patient underwent cesarean because she has a severe respiratory distress. So we have to deliver the baby by cesarean section. So otherwise, our experience with COVID-19 is that majority of them were asymptomatic, and most of the women we gave prophylactic heparin because most of them, they were fulfilling the criteria because they were complicated. Like we have every kind of complication: eclampsia, acute pancreatitis, PPH, retained placentas, placenta accreta. So all kind of obstetrical patients we have seen. Uncomplicated patients were very less. So because we have a tertiary care hospital, so any positive patient they used to refer to us. But as such, COVID-19 impact, we didn't see so much of morbidity. And there was one case where the baby was also found to be positive. At the time of birth, we took the sample, nasopharyngeal swab, rectal swab. Breast milk was also positive, and RT-PCR of the placental tissues from fetal and maternal surface and vaginal swab. Everything was positive. So this was the case of vertical transmission because that breast milk showed positive RNA for next subsequent 13 days. So this was the case where we could clearly say that it is a case of vertical transmission because at the time of birth, baby had a severe respiratory distress. We get the X-ray done of the baby, and baby has that typical ground glass opacities on chest X-ray. So almost all evidence we got in this case. But rest of the cases, we didn't find any case of this vertical transmission. We did iatrogenic cesarean section in any patients because I share too that 33-weeker placenta previa 2 episodes of bleeding. We didn't have so much of, staff to monitor her there in COVID wing and seeing day and night. So this was our experience. Otherwise, the rest of the patients, they were not too complicated from COVID-19 point of view.
Thank you, Dr. Bharti.
Yeah. Bimla, whether Dr. Gadappa has any data, whether he has any?
Yeah.
No, I don't think.
BMC Aurangabad is conducting a study with ICMR also. It is a COVID registry for mother and neonate. We have got 262 cases of COVID positive mother delivered, out of which most of them were asymptomatic. We have got 2 mortalities, maternal mortality, but they were having the condition of severe preeclampsia and other was a abruption with HELLP syndrome.
It was not related.
Woman we cannot survive, but the other women were survived and the babies were also good. Only thing, we have got 4 babies who are positive after 5 days because we were encouraging breastfeeding in COVID also. So somewhere some problem, hand hygiene or respiratory hygiene not followed. So 5 babies came positive, and but they cured without any much treatment.
Correct. I just wanted to put in here that Foxy has formed a registry for collection of data from its members. I think Dr. Gadappa must have submitted.
Yes,
I
yes,
hope
yes.
you have too, Bharti. that there is a link for submission of data to Foxy, and
Ma'am.
we may come up with a very large number of women and their outcomes. So Dr.
ma'am,
Alpesh Gandhi has made that effort. Yeah, thank
Okay,
you.
with WHO and ICMR, we are sharing, ma'am, because we and allied centers have shared 600
Okay.
females data, but that is
Okay.
WHO and ICMR both project is going on. But
Okay.
with
WHO is doing a study on this. So
ma'am, WHO for 6 months we have already registered. ICMR is continuously asking for the portal entry. So with allied Chandigarh hospitals, almost we have 600 pregnant patients data. So
Okay, that's great. Yeah.
the
Yeah.
next question, can we take the next question? How can government doctors be allowed to charge for telemedicine, keeping in mind the non-practicing allowance? If anybody wants to answer, Dr. Dilip has already left.
Yeah. Do you wish to take this, Dr. Gadappa?
Yeah, at present, once you are taking a not practitioner allowance, you are not supposed to take any private fees, whether it is telemedicine or you are doing any consultation. So
Okay.
officially government doctors are not allowed to take any charges, but in medical colleges like us, we have got a telemedicine facility where one area is identified where the patients are given advice on telemedicine for peripheral doctors, and their remuneration is there. They are charging 200 rupees for this, but that is a government remuneration.
Thank you, Dr. Gadappa. And the last question is taking consultation regarding patients' data like ultrasound or investigations from other specialities. I think it is regarding the telemedicine itself. And for
I didn't understand this question actually.
I also not able to
Uh,
understand this.
maybe Dr. Sita Thakur can put in a little more or the text there to make us understand.
Or if she can,
Or she can unmute and talk if she is enabled. Yeah. That's possible if she can talk. Yeah. So I think it was a very useful discussion, Vimla. Yeah. Yeah, Sita. Yeah.
It was regarding like somebody sends me ultrasound report or some CT report and all. Some patient sends to me on WhatsApp. Can I take a consultation from the radiologist on that that ultrasound or a CT scan?
Didn't understand.
Like I have some patient sends me some investigations or some CT scan report.
You mean to say that whether, because you sometimes when
can I take the consultation from the radiologist legally in telemedicine?
I don't think that can be done in a WhatsApp platform. What you can do instead, I do not know about from sonologist. I do not know how that system works. What I can advise you here is that you use a regular encrypted platform for teleconsultation, which is through your clinic, enabled through your hospital. It is a professional platform enabled through your hospital or through your nursing home or through your clinic, not on WhatsApp. WhatsApp is not a legalized platform for teleconsultation. It is very loosely structured and no confidentiality is maintained. Of course, patients share us information all the time, and we just answer in monosyllables, sometimes yes or no, and that's all. We do not actually consult on WhatsApp. It's only meant for patients' reassurance. We finally opine on the entire only when they come or on a teleconsultation platform. So you have to use a platform, and on that, whatever reports she wants to show to you, take your opinion. For that you can put charges. That is possible. So it is like a follow-up visit that you would do in a clinic. She has come back with all her reports and she wants to show to you, then you can charge a consultation fee which you would normally do otherwise. So whatever you normally do in your clinic regarding consultation fee, and whatever you do in your ethical practice, so same thing can be done on teleconsultation platform, but the platform should be a safe one. That's all. Yeah.
Thank you, Dr. Shobha, for I think that is a clear answer to this question. And we are like coming to close, and any last minute remarks from anybody is welcome. Dr. Gadappa has to leave at 6:30, I assume.
Yeah.
Send in a mail.
Yes,
So
ma'am.
Any last minute remarks from the
Yeah,
panelists?
Dr. Kadapa, anything you want to convey from your vast experience? And I
Uh,
think Bharti gave very valuable inputs like that. You were not allotted a talk, so I just wanted your experience.
No, actually, it was a very good platform you have created, because this pandemic there was a lot of controversies and lot of new guidelines were came. But now there is a crystal clear thing that obstetrician we can do lot many things, and there should not be any panic situation. And one positive thing around this is that the women who are pregnant, they are least susceptible for this infection, and the gravity and the severity is also less. The mortality is also prevented if it is taken in time. And breastfeeding is the most important thing in COVID that should be done, because in 262 cases we got a good result. So nobody should be worried about that. So this practice should be concealed, and the woman should be encouraged to do give breastfeeding. That is what I want to say.
Excellent. Yeah. So they are not as high risk as we thought that they would be, but of course they need closer follow up. And one thing which I think Dr. Walke also mentioned, but I just wanted to ask you that the principles of teleconsultation, what will be the minimal number of teleconsultation in the antenatal period, and if at all, when she should come and meet us in person?
Now in the even the advisory has said that the antenatal clinic should be minimized, and they should be asked to attend for some high risk cases. And only thing is that they should be encouraged that in less than 20 weeks they should have one ultrasound anomaly scan, because during this period most of the women does not turn out, and then anomaly detected after 20 weeks. So we have increased, so that should also be given in this. And this because telemedicine is there, but the woman was not knowing that where to contact. The most of the women, they used their telephone number and WhatsApp for that. So this is that the once they miss the period, they should have one consultation, less than 20 weeks one, and then after 28 weeks one, and then at 36 weeks. So minimum 4 visits, as government of India says, it should be there on teleconsultation also.
Minimum 4 visits. Yeah. That is what.
One thing, ma'am, may I add, as Dr. Gadappa also said, that the problem with the abortion services through telemedicine is that even WHO, all the advisories, they say that while providing the home-based management, it should be ensured that the women has access to the services. The patients who come to us, the first thing is that, madam, the number बड़ी मुश्किल से आज लगा है. सो अगर उनका नंबर बड़ी मुश्किल से आज लगा है, जो कि इलेक्टिवली उन्होंने अबॉर्शन के लिए सिर्फ अभी काउंसलिंग लेनी थी, सो how can we expect them to call up in the middle of the night, I'm having this problem or that problem? That is a major issue in our setup. So they should have an access to the services immediately, number one. And second thing, as sir has just said, that yes, I would like to add on that NRHM has issued a guideline on ultrasound in pregnancy, where they have recommended one scan at 18 to 19 weeks.
Yes.
That is a recommendation now, ma'am.
Correct. Yeah.
Thank you.
So four visits and one scan is the minimum, and 2 shots of immunization minimum, and the supplements, and then the warning signs have to be told to the woman, possibly over teleconsultation, when she should come and visit. I think Bimla, can you please conclude? I think it is.
I think we need to conclude, and um, it was a very nice and very informative talk given by all the panelists, and the discussions which happened around the issues. And I hope and I believe that this changing scenario is bringing in very good and good innovations as well, and we will continue to provide the reproductive and maternal health services during and after the COVID pandemic, and with new ways of dealing with the situation. Thank you, Foxy. Thank you, PGI, and everyone, the participants, the panelists, everyone, for making this a good session. And I hope all of you have gained a lot. I myself have gained a lot from this. Thank you, Dr. Neena. Thank you, Kiranji, Dr. Shobha,
Thank
Dr.
you.
Bharti, Dr. Rimpi, Dr. Gadappa, Dr. Dilip,
Thank you.
all of you.
Thanks, everyone. Yeah.
Thank you, everyone. Thanks.
Bye.
Thanks,
Thank you,
everyone.
madam. Thank you.
Really, thanks.
Ma'am, And there's actually one question. I think if we can take it, I think it is from a faculty of a medical college. Like Dr. Renu Bedi is asking that who is going to make women aware of number and schedule of visits? If we can take that. Dr. Rimpi, Dr. Bharti.
Let me go through the question again.
Yes, ma'am. It's in question and answers. That who is going to make women aware of number and schedule of visits? I think maybe.
I think the first time she is going to take a teleconsultation, at that time because whenever she has an encounter with a physician, whether it is through teleconsultation or whether she has visited in person, next time she can be called upon and said that this is a kind of pregnancy you can follow through the teleconsultation if somebody has gone through. That is
exactly.
because
We will come to know only when, we will come to know for women's pregnancy only once she consults. And at her very first consultation, she can be made aware. And moreover, if she's having any complication, any medical disorder, then obviously we can advise her a closer follow-up also. So it is only, I think the clinicians need to be more aware that these are the basic 4 visits that are required. So we can always advise them once they consult.
Yes, ma'am. Okay. I think that was all. One question, Hanji. Thank you so much, ma'am, for your valuable time. And this CME is available on YouTube, ma'am, on a YouTube channel. I think I can share the link and it can be further shared with your
and they need to fill a feedback form also.
I will mail, yes, a feedback form for both the CMEs, ma'am. I will mail all the participants for their feedback, and certificates will be issued likewise. Thank you, ma'am. With this, I close this CME.
Thank you. Thank you,
Bye,
Dr. Bharti. Thank you, Dr. Rimpi.
Thank you, ma'am.
For the opportunity. Thank you. Thanks a lot.
Thank you.
Thank you, Neena, ma'am. Okay.
Thank you. Bye-bye.